Good afternoon, everyone. I would like to welcome you to today's presentation titled Demystifying Higher Level of Care for Eating Disorders. There are a few things to note before I introduce today's speaker. Participants will be muted upon entry and videos turned off. For technical assistance, we ask that you use the chat box located at the bottom of your screens. You will also receive an email approximately 1 month from today requesting feedback and impact on today's presentation. We also ask that you visit our training center at www.ncdas.org/training to view other training opportunities that NCED has to offer. This training will be made available on our training center within 2 weeks from today. We will also have a question and answer segment at the end of this presentation. Any unanswered questions will be sent via email 1 week from today's date. Slides from today's presentation and other resources will be made available immediately after today's presentation. I'll now go ahead and introduce today's speaker. Dr. Tanya Foreman is a professor of clinical psychiatry at the University of North Carolina at Chapel Hill. After graduating from the University of Kentucky College of Medicine, she did an adult psychiatry residency at Vanderbilt University, a child and adolescent psychiatry fellowship at the University of Florida, and a forensic psychiatry fellowship at Yale University. She was on the medical school faculties at Tulane University, University of Louisville, and Indiana University before coming to the University of North Carolina. She has won numerous awards, including the Ginsberg Fellowship from the Group for the Advancement of Psychiatry and the Rappaport Fellowship from the American Academy of Psychiatry and the Law. I'll now turn things over to today's speaker, Dr. Tanya Foreman.
Thank you, Lachelle. Good afternoon, everyone. Lachelle, I'm having trouble moving my...
You're not able to advance the slides?
No. Let's see.
Do you want to close and start back over?
Yeah, that's what I'm trying.
It's not allowing you to close it?
No, I'm going to stop share
Okay,
and
go.
try it again.
No problem.
No.
That's strange that it's not allowing you to share. We're asking that you all be patient with us. We're gonna begin presenting shortly again.
Am I sharing now, Lachelle?
Yes, you're sharing now.
All right. I apologize, everybody. I'm old. I'm starting to feel like, you know, one of those memes or one of those jokes, much as I don't want that to happen. That's how I feel.
You're fine. You're absolutely fine. So you took this, it came off again. So you have to go back and share again.
Yeah, I'm gonna get there. Okay.
from the beginning.
All right, let's
Okay.
hope it advances. Here we go.
There we go.
All right.
Perfect.
Sorry, everybody. The audience for this talk is clearly not IT folks because I have nothing to share in the IT realm. The audience is intended, however, for outpatient clinicians, including primary care clinicians, outpatient therapists, and outpatient dietitians. The goal for this talk is to educate outpatient clinicians about higher level of care for eating disorder treatment so you can know when to refer patients to higher level of treatment, have realistic expectations for what treatment entails, inform your patients about what to expect during treatment, and interface effectively with patients after they complete higher level of treatment. Indecision may or may not be the problem. Patients with eating disorders often have extreme ambivalence about seeking treatment, and it's rare that a patient will present to your office asking to be admitted to a higher level of care. Therefore, it's incumbent upon outpatient clinicians to know when a patient with an eating disorder needs to be referred for inpatient or residential treatment. In addition, you'll be in a better position to persuade the patient to seek higher level of care if you have an idea about what that treatment entails. Levels of care for eating disorder treatment. First, there's obviously inpatient treatment that can occur on a medical or pediatric unit, a general psychiatric unit, or a specialty eating disorder facility. It might or might not occur in a locked facility. Next, there's residential treatment, which is 24/7 supervised treatment, may or may not be locked. Often residential treatment centers are in home-like setting, and they have 24/7 nursing and site on staff. There are some alternatives to 24/7 treatment. Partial hospitalization program, or PHP, is basically day treatment where patients go to the treatment facility for 6 or more hours a day. Intensive outpatient program, or IOP, usually meets 3 or more days a week for several hours, sometimes in the evenings. A benefit of IOP programs is that the patients can often continue to go to school or go to work while they do an IOP. And PHP and IOP are important treatment settings for patients with eating disorders, but for the purpose of this talk, I'm going to focus on inpatient and residential treatment. Inpatient treatment. Well, who needs inpatient? Consider referring a patient for medical hospitalization if they have a heart rate of less than 40 beats per minute, blood pressure less than 90/60, potassium less than 3, electrolyte imbalances, hypothermia, dehydration, end organ compromise requiring acute treatment, or poorly controlled diabetes. Also considering hospitalize a patient with an eating disorder if they have had a rapid or significant weight loss, or if they're substantially below target weight. What you might notice is missing from this slide is an exact BMI or weight for a person to need inpatient treatment. It really depends on how much the patient has been eating and what their nutritional and weight trajectory has been when you make the decision of whether or not to refer for inpatient treatment. This is an aside, but I think many people aren't aware of it. Electrolyte abnormalities are generally only found in patients with eating disorders who purge. Patients who restrict often have normal electrolytes. So people can be really, really sick and really low body weight and need to be hospitalized, but they might have normal electrolytes. So therefore, as you consider whether or not to refer your patient for inpatient treatment, please don't rely exclusively on lab results because they don't tell the whole story of how ill or at risk a person might be. I want to make sure everybody is familiar with atypical anorexia, or OSFED, which stands for other specified feeding or eating disorder. An example of someone with OSFED might be a patient who weighs 250 pounds, but restricts and only eats 300 calories a day. This patient might need referral to an inpatient treatment setting to restore sustainable eating patterns. OSFED patients, even though they are not at what we would consider to be a low weight, can be at the same refeeding risks as patients with anorexia nervosa, and they may need inpatient treatment. Okay, back to various types of inpatient treatment. Hospitalization on an inpatient medical or pediatric unit would generally have the patient staying in a traditional hospital room, and rooms on medical and pediatric units are not locked, so the patient might need to be placed on a one-to-one to monitor for eating disorder behaviors or if there are concerns regarding suicidality. What are the potential benefits of hospitalizing a patient on a medical or peds unit? First, these units are necessary for patients who are medically unstable. No other unit would be appropriate if the patient needs IV fluids or IV electrolyte repletion or telemetry. In addition, access to specialty medical or even surgical consultation can occur easily from a medical or peds unit. Another potential benefit of hospitalizing a patient on one of these units is that it might be easier to persuade that patient to be admitted if they know they're going to a medical or peds unit than to a psychiatric unit. A potential limitation of hospitalizing a patient on a medical or peds unit is that the staff on those units might not have much experience treating eating disorders. The one-to-one sitters that would be with a patient are not likely to have any eating disorder experience. And in some facilities, the one-to-one literally is just a person who sits by the patient to make sure they don't attempt suicide or elope. Typically, medical and pediatric units don't offer group or individual psychotherapy. Some hospital units, especially peds units, have excellent eating disorder protocols, but others just don't. The unit dietitian might not know how to help a patient with an eating disorder develop a meal plan or make food selections. The patient is unlikely to receive psychoeducation about the eating disorder or to be given an idea of what treatment beyond the hospital can entail. Case managers on general medical or pediatric units are unlikely to be familiar with aftercare resources for patients with eating disorders. Having family visiting at the bedside can be helpful or detrimental depending on the situation. If the family has enabled the eating disorder or is highly enmeshed with a patient, having them at the bedside, as is usually offered on medical or pediatric units, can present challenges. So if hospitalization on a medical or peds unit isn't indicated, what would be the pros and cons of hospitalizing the patient on a general psychiatric unit? On the plus side, psychiatric units are generally designed to provide an environment that protects patients with suicidal ideation. Staff are trained to watch for potentially dangerous behavior. Another potential benefit of being on a general psychiatric unit is that involuntary hospitalization procedures can be implemented easily if needed, and sometimes that is necessary for patients with eating disorders. There are challenges with being on a psychiatric unit, though. Whether we like to admit it or not, there is stigma associated with psychiatric units, and I've known many parents who could more easily accept that their child might have a serious gastrointestinal condition that requires hospitalization on a pediatric unit than to accept that their child has an eating disorder, a psychiatric condition. Also, psychiatric units are scary. As increased safeguards have been put in place to prevent suicide in hospitals, psychiatric units have become even less cozy, if they ever were cozy. The furniture is institutional, minimal decorations are allowed, activities that could be good for coping strategies often have to be limited due to safety concerns, and general psychiatric units typically have a mixed milieu of patients with assorted psychiatric illnesses. It could be frightening to be on a unit with a person who is acutely manic or is having a psychotic episode. Access to a dietitian with eating disorder experience may be limited for patients on psychiatric units. Accurate calorie counts and ins and outs of body fluids can be difficult or impossible to obtain. Blinded weights are commonly performed in eating disorder treatment settings, and many eating disorder programs don't tell the patient what their weight is. If the staff on a general psychiatric unit, or a medical unit for that matter, isn't used to doing blind weights, patients might find out their weight, and that is extremely triggering. Even if the patient is prevented from exercising in their room, they might pace around the unit or do other forms of excessive body movement without being noticed by the staff. Bathrooms on inpatient psychiatric units are often not locked, and patients may be able to purge. Other patients might not understand eating disorders, and they can make comments that are triggering. For example, they might say something like, "If I had a body like yours, I wouldn't be suicidal." They might engage in diet talk. Other patients might speculate about psychotropic meds that cause weight gain. Commonly prescribed activities that can be intended to promote a healthy lifestyle might be triggering for patients with eating disorders. For example, if a group leader encourages patients on the psychiatric unit to exercise more or cut back on sweets, that could unwittingly reinforce the eating disorder. A big challenge on general psychiatric units is that NG tubes might not be allowed. Therefore, there's little recourse if a patient is refusing to eat or not eating enough, unless that patient becomes medically unstable enough to have to be transferred to a medical or pediatric unit. And the likelihood that the eating disorder patient will receive much focused eating disorder specific treatment on a general psychiatric unit is low. So what happens on a specialized eating disorder unit? There are clearly some benefits of specialized eating disorder units. The staff are trained and they're familiar with how to monitor and support patients with eating disorders. There should be protocols in place to monitor weights, vital signs, and labs. Staff should be trained to provide meal support and to monitor for eating disorder behaviors. Bathroom support can be provided to prevent purging. Accurate bowel movement records can be kept to try to reduce laxative-seeking behavior. And a dedicated dietitian can provide specialized meal plans and education for patients and their families. But what are some challenges of being on a dedicated eating disorder unit? First, there is a possibility of contagion and competition. Eating disorder patients thrive on competition, and every new admission to an eating disorder unit creates a cascade of emotions in all the patients already on the unit. Patients inevitably believe they are the biggest patient on the unit. They might feel unworthy of receiving treatment. They might want to compete to be the sickest or to do their eating disorder well enough to have medical complications. If NG tubes are used, patients might see having an NG tube as a sign of success in having an eating disorder that made them sick enough to require a tube. Chronicity can also be a problem. Patients who are repeatedly hospitalized or hospitalized for long periods of time in eating disorder settings can become more attached to their eating disorders, and it might become their identity. So what actually happens at inpatient treatment, regardless of what type of unit a patient is on? The primary and arguably the most important thing is medical stabilization and monitoring for and preventing refeeding syndrome. Well, what is refeeding syndrome? It's the sudden cardiopulmonary collapse that occurs during the early phase of nutritional rehab in a patient who is malnourished. And here is technically what happens when somebody has been starving or very malnourished and you reintroduce glucose in the form of food or nutritional supplement. It stimulates insulin secretion, and that promotes the uptake of glucose, potassium, magnesium, and phosphorus into the cell. Phosphorus is necessary for protein and glycogen synthesis, and it can become depleted. Therefore, you may not have the basic building blocks necessary for your cells to function, and this can result in cardiopulmonary strain and even collapse. I like simple explanations, so when I think of refeeding syndrome, I think of it as being like trying to build a house without any scaffolding. So you may have all the resources necessary to build the house, but if you don't have scaffolding, it's going to fall apart. In addition to monitoring for refeeding syndrome, most patients at inpatient and also residential treatment need some amount of weight restoration. What is the safe rate of weight gain that can happen at inpatient or residential level of care? It's about 3 to 4 pounds or 1 to 2 kilos per week. Other things that can happen in the inpatient setting would be the patient is safely contained, usually in a controlled environment. They might be introduced to eating disorder and recovery language, and hopefully the staff can start laying the foundation for recovery. And hopefully, as the patient starts being better nourished, their cognitive rigidity might improve. And this is really, really important. When people are very malnourished, they have trouble with rational thought and they can have extreme cognitive rigidity. So just having better nutrition is powerful medicine in and of itself. And that's something that can happen at inpatient or at residential treatment. One treatment modality for adolescents that might be introduced at inpatient treatment is something called family-based therapy, or FBT, or you may hear it referred to as Maudsley method. And this is an evidence-based treatment for adolescents with eating disorders. It's a manualized treatment delivered by trained professionals. And I think when you hear family-based therapy, you might think, oh yeah, I know what family therapy is. But FBT is actually a very specific type of therapy for patients with eating disorders. And some programs use that as their foundation and teach the parents how to do it. And basically the idea of FBT is that if an adolescent is in the throes of an eating disorder, the adolescent really isn't able to make their own food choices. The food choices are going to be driven by the eating disorder. Therefore, the parents are coached and taught about how to nourish their child and make all the food decisions for the child during the early phase of recovery. So how long do people stay at inpatient level of care? These are super ballpark, but roughly they may stay at an inpatient psychiatric or specialized eating disorder unit until approximately 85% of their target weight if they're being discharged straight to outpatient level of care. If they're going to residential or maybe PHP, they may only need to stay at inpatient until they reach approximately 80% of target weight. Medical and pediatric units are generally not able to keep patients this long, and they discharge them often at lower weights. And again, these are super rough and super ballpark, but it gives you some idea. Before people leave inpatient, generally they need to be eating solid food, they need to be able to maintain nutrition, and probably need to be gaining weight. So let's shift now and talk about residential treatment. Residential treatment is often confused with inpatient treatment. Both are 24/7. Residential treatment is much less likely to be secure. Some residential programs are locked, but probably most are not, so it might not be appropriate for someone with a high risk of suicide. However, the additional freedom available at residential treatment gives some additional benefits. Many residential treatment programs are in beautiful environments with access to nature. They're often in home-like settings, and this is not only more comfortable for the patient, but it more closely replicates what their environment will be like after discharge. The meals are more likely to come from an on-site kitchen and be less institutional. At residential treatment, the patient has a weekly visit with a psychiatrist rather than a daily visit with a medical clinician, which is what they would have had at inpatient. There's 24/7 nursing and 24/7 support staff at residential. There's dietitian support. There are multiple therapies. The patient should also receive family therapy. There are a variety of groups. If a patient is an adolescent, there is usually some sort of accommodation for school or time to do schoolwork. One of the important features of residential treatment is the milieu. And the definition of milieu is the person's social environment. And the milieu is like an invisible force that has a positive or negative effect on the treatment of every patient. And I think of the milieu as an invisible patient. Something that we often tell patients in residential treatment is that they and their peers can do their eating disorders together, or they can do recovery together. And obviously, we hope they'll choose to do recovery together. But to me, one of the most enjoyable aspects of working in a residential environment is trying to maintain a therapeutic milieu so that the patients support each other. So if the milieu is one of the most important aspects of residential treatment, another key aspect, obviously, is food. Lots and lots of food. Most residential programs serve 3 meals and 3 snacks per day. That means patients are eating 6 times a day, so a lot of time is spent at the table eating. The food is not only for nourishment, but it's also an exposure and an opportunity to practice eating in a supportive environment. Typically, if the patient won't complete the food, they're offered a liquid supplement such as Boost or Ensure. So let's talk about the meal plans. In the hospital, meals are likely to be ordered from a menu, a typical hospital menu, and they're often planned a day or 2 in advance, hopefully with some specific input from the dietitian. Patients at inpatient or residential treatment may be introduced to nutritional exchanges. For example, they're guided on how many starches, proteins, or dairy exchanges to order at each meal. And the number of exchanges can be increased as the patient moves out of the risk period for refeeding syndrome and into the weight restoration phase. Most residential programs have a few meals that the patients don't plan or know about in advance, and the patients don't get to select them. Patients with eating disorders experience a high need for control around their food. So part of the exposure process and treatment is for them not to know what might be served at some meals. This produces anxiety and discomfort, but it's better for patients to deal with those emotions in a supportive environment so they can manage and practice their coping skills. And I want to tell you a story that happened to me many years ago, early on when I was just starting to work with patients with eating disorders. And I worked in a residential setting, and there was finally time in the program schedule and in my schedule for me to do a group. And I was really excited because psychiatrists don't often have opportunities to lead groups. So I put a lot of thought into what I wanted my group to be. And I finally decided we were going to do a mindful eating exercise with raspberries. So I went to the grocery store and I got the most beautiful raspberries I could find. And I imagined us each taking one raspberry and examining it and looking at the little whiskers on it and thinking about the farmers and being grateful for the farmers and the sun and the soil. And that it was just going to be a really beautiful, mindful eating opportunity. We went in the group room. I took out the box of raspberries. One person audibly gasped and said, "I can't do sweets." Two people had to leave the room crying with staff members. Everybody else was incredibly uncomfortable and unhappy about being asked to eat the raspberry. I was getting a little irritated because I bought those raspberries with my own money. I made a special trip to the grocery store. This was going to be my big moment in this group. Needless to say, it was a failure. The next morning, my colleagues saw me at work and they asked, "Hey, Tanya, how'd your group go?" And I said, "It was terrible, thanks." And they said, "Yeah, we knew it wouldn't go well. Impromptu eating experiences with patients don't tend to go very well." In hindsight, I am so glad that my colleagues let me do the group, because if I hadn't been in the room and saw how organically the distress unfolded for those patients, I wouldn't have believed it. I would have thought it was hyperbole if somebody told me they would become that upset, but I saw it with my own eyes. And so the way I've come to understand that experience is that sometimes in treatment, patients might know they're eating a very high number of calories. They may be eating 3,500 or 4,000 calories a day. And they can kind of wrap their head around that and do it if they know that it is prescribed by the dietitian and that it is being tightly monitored and if it is part of a scheduled plan. What they can't tolerate, though, is the unexpected curveball of being asked to eat even one raspberry. Family style meals are one sort of meal paradigm that some programs might use. And I worked at a program that did this. And so many staff members ate at the table with the patients. We all ate the same food, and the goal was to normalize eating together. I find eating meals with patients to be a helpful way to learn about how the patients are functioning in the milieu and with their meals. And in addition, when we eat with the patients, it's an opportunity for the patients to see that we're eaters and we can model eating spontaneously and joyfully in a community type setting. So the way we did it when we did the family meals at the program where I worked was that the food was in, family-sized serving dishes, and we were all told what a serving would be. And so the dishes were passed around, and we each took the designated amount of each item. Because we were all eating the same food, it reduced competition and comparison. You might wonder how patients gained weight if we were all eating the same food. And the way they gained weight is that even though our meals were all the same, snacks were different. And so if patients were on a weight restoration program, they would be given these very nutrient calorie dense shakes at snack time. Although I loved eating with the patients, some meals were very awkward, as in everybody's sitting at the table, some people potentially near tears, nobody making eye contact. It's typical that in eating disorder settings at the table, Word games or little trivia games are played. Sometimes music is played. So the goal often is to distract people from the stress of eating itself. Staff don't humiliate patients if they're struggling or if they're engaging in eating disorder behaviors at the table. So it is not a militaristic attitude. If redirection is needed, it happens very discreetly and sometimes might not even happen until after the meal or until after most of the other patients have left. Cooking group is an important activity that occurs in residential treatment settings, and cooking group provides a number of benefits. A lot of patients just don't have basic cooking skills. They may not have any idea how to follow a recipe. They may need education about safe food handling or knife skills. Cooking group is also a chance for the group leaders to see if patients are trying to be sneaky and maybe not put in the amount of oil or sugar in a recipe. And these challenges with touching and preparing food can be anxiety provoking for patients, but they're important practice opportunities. Having delivery food or going to a restaurant is an important experience for patients to have. Eating restaurant food can be challenging because patients may see the calories on the menu. They may believe that restaurant food is bad or unhealthy. They may be uncomfortable because they can't see the food being prepared. Many patients with eating disorders are uncomfortable eating in front of other people because they think that people will judge them. At one program where I worked, Friday night was delivery pizza night, and everybody knew that. And the patients would start getting apprehensive about noon on Friday, and they would dread the pizza delivery. I, on the other hand, often tried to work a little late on Friday so that I could maybe score some leftover pizza. Family meals. In residential treatment, the clinicians attempt to learn about the food environment in which a patient grew up. So did the patient experience food scarcity? Did they grow up steeped in diet culture? Does a family member have diabetes or celiac disease or some other condition that caused scrutiny of food? I worked in a program where a dietitian and therapist ate lunch with every adolescent patient's parents on the day that the patient was admitted to treatment. And this was an incredible opportunity for the team to get to learn firsthand about the patient's family food environment. And we had parents who had meltdowns because they were served a cookie. One parent insisted on only eating macronutrient bars, and he wouldn't even touch any of the food that we provided. This information gave us an invaluable glimpse into how the family had contributed to the patient's food beliefs, and it gave us areas to focus on in family therapy. Individual therapy is obviously an important part of residential treatment. It serves many purposes, but one of the key features is that the therapist takes a comprehensive history and can share that with the team. This process of taking the history also helps the patient feel seen and understood and helps them start creating a narrative for their life. ED is an acronym for eating disorder, and it's important for the therapist to know who the patient is as an individual so they can help the patient start separating from the eating disorder. A visual that I often give for patients is two intertwined hands. And I think if this is the eating disorder, this is the patient. When a patient is in the throes of an eating disorder, you can't look at these hands and even tell which finger belongs to the eating disorder and which finger belongs to the patient. And so much of the work that we do in helping patients try to identify ED cognitions or ED behaviors is to help them start wriggling free and to realize what is ED versus what is their own more recovery-minded thoughts and behaviors. And literally recovery is hard. ED tries to pull the person back, and people have to work very hard to pull away from the eating disorder. So one of the things that the therapist can do is help the patient start to visualize, what can my life look like without the eating disorder so that it's worth it to me to do this hard work of pulling away from ED and moving toward a life in recovery. Motivational interviewing is the cornerstone of our interactions with patients, and our role is to help them realize that there are better things in the world than to remain entangled with their eating disorder. We also try to help them identify what purposes the eating disorder has served to see if they can get those needs met in a different way. Nurturing deficits. It's not uncommon for patients to have experienced nurturing deficits. And in a residential setting, the presence of staff, including the patient's individual therapist, all day in the environment is therapeutic. It's kind of like having a parent in the house. It also provides an opportunity to teach boundaries. So just because the therapist is in the building, the patient has to learn to refrain from seeing that therapist at the drop of a hat. They have to learn to hold their emotions until the next therapy session. The patient might see their therapist interact with other patients, and this can create jealousy. All of these emotions are grist for the therapeutic mill. Family therapy is an important component of residential treatment, and it's an opportunity to provide psychoeducation to the family or support people in a person's life. The family therapist can help members improve communication and assess and solidify resources and supports for the patient, and they can help coach the family members about how to provide effective support for the patient after discharge. Therapeutic groups are important in residential treatment, and there are many, many different types of therapeutic groups. Not all programs have all of these groups, but here are some examples of the types of groups that might typically be found in programs. Here are some more examples. Yoga or some sort of mindful movement is important because often patients with eating disorders have a very unhealthy relationship with movement, and they need to start being allowed to do some physical exercise that is not focused on burning calories or modifying their body. And at the bottom of the list, you'll see animal-assisted therapy. This is something that I care a lot about. These are my dogs. I believe that animals can be important and powerful tools in working with patients with eating disorders, and I'm fortunate that I've been allowed to bring my dogs to work for the past 11 years, and I've used them in many ways. We've practiced doing physical exams on the dogs to learn about vital signs and body physiology. I've had patients train the dogs to follow commands, and this is great because the dogs won't follow commands unless the patient is firm and authoritative, and that's hard for some of them. You know, if a patient just says, sit, the dog is not going to sit. And so having the patience running the dogs through the commands gives the patient a chance to get in touch with their own power to actually affect change or cause something to happen. One of my favorite things that we did was a dog election where patients, I have 3 dogs, and they campaigned for which dog they thought would be the best mascot to fight eating disorders. And so they made campaign slogans and t-shirts and signs, and we had a town hall meeting where patients gave talks about what characteristics of the dog was the best to fight the eating disorder. The dog that ended up winning actually won by a landslide because the patients gave a really compelling speech and said, this dog has had physical health problems, they're anxious, but they're an overcomer. And those are the features that are needed to fight an eating disorder. And it was a really beautiful experience where the patients got to advocate for something, because self-advocacy and advocating for others is often hard for patients with eating disorders. One of my favorite activities is something called Project Runway, which is a riff on the TV show Project Runway. In Project Runway, I would bring a bunch of fabric and ribbons and tape, put it in a pile, divide the patients in team, and give them their model, which was one of the dogs. And they would be given 15 or 20 minutes and told, you have to come up with an outfit, and then you have to just make it work. This was a lot of fun because we could poke fun at the fashion industry. They had to work in teams. It challenged perfectionism big time because sometimes the models were not cooperative and we had wardrobe malfunctions. But it was a really special experiential way for patients to learn to work together and to learn that things don't have to be perfect and to learn to be spontaneous. A group that I did for many years was called Power Tools. And the idea behind Power Tools was that if a patient had an interest or a skill that they could share with other patients, then in Power Tools, they would have a chance to do that. And one of the very first Power Tools that I did involved a patient who was a telemetry nurse. So she sat in front of heart monitors every day looking at the heart monitors. And she said, oh, I really want to do a group and teach patients about EKGs. I thought to myself, oh, this is not going to go well. This is going to be really boring, and it's going to make her feel bad. but she wanted to do it. She was excited about it. So she prepared a handout talking about the technical aspects of EKGs, and she explained that. And then at the end, she beautifully talked about connecting of the heart. So beyond the mechanics of the heart, but why she cared as a telemetry nurse about the hearts of her patients. And it was absolutely beautiful. And the other patients were captivated. And what that experience taught me is that if you can give patients in treatment an opportunity to step into a position of strength or to connect with something that is valuable to them or something about which they feel passionate, that is enormously healing. It also gives their peers a chance to see that person in another light. So I did Power Tools for many years. The program where I work now does Power Tools, and I always love hearing what patients come up with and what their experience is in stepping into leadership for a moment, even while they're still in treatment. The challenge of having idle time. In residential treatment, people have time on their hands and they have to fill it in a healthy way because the groups and the meals don't occupy 24 hours of the day. And this is difficult for a lot of people, especially folks with substance use disorders or those who are very driven and can never slow down. A lot of our patients have an urge always to be productive, so teaching them to play or be still in silence is important. Okay, so what happens when our patient receives treatment at a higher level of care? They're getting all these great treatments, they're going to groups, they're having all these individual therapies, they're getting better nourished, and every day is just rainbows and unicorns. The patient is feeling so much better and they're on the road to recovery. No, patients feel worse before they get better. If I had $1 for every time a patient has said to me, being here is making my mental health worse, my antidepressant isn't working anymore, everything is just getting worse. When a person is in inpatient or residential treatment for their eating disorder, their distress is likely to increase. Eating disorders are unlike nearly all conditions you'll treat because the patient is likely to feel ambivalent at best about recovering. When a patient comes to you with a broken leg or a headache, you and the patient will be on the same page about the desired outcome. You want the leg to get better. You want the headache to go away. Patients with eating disorders have worked hard to become so ill, and it may feel like an achievement to them. Recovery might feel like a loss. Eating disorders are maladaptive coping mechanisms for sure, but they do provide some temporary distress reductions for patients. And when you put that patient in an environment when they can't act on their eating disorder behaviors, emotional distress is going to increase. And I often use the analogy of a balloon with patients. So if you picture a balloon and you squeeze on part of it and compress part of it, it splooges out in other directions. So if we squeeze on a patient's eating disorder and don't let them do their eating disorder behavior, other impulses and other emotions are likely to splooge out. So for example, if a patient is in treatment and they're making concerted effort to reduce their eating disorder behaviors, the urge to use substances may increase, the urge for self-injury may increase, or even suicidal ideation might increase. Developing coping skills is one of the core tenets of DBT, or dialectical behavioral therapy, which I'm sure many of you are familiar with. If you're not, I do recommend trying to familiarize yourself with some of the basic terminology of DBT because it will help your patients if you speak the language that they're learning in therapy. Coping skills is an important part of DBT, and a lot of the work of overcoming an eating disorder involves replacing maladaptive coping skills with less destructive ones. When patients are in distress, they understandably want something that feels 100% effective and works immediately. That's not how coping skills work, unfortunately. And a cornerstone of eating disorder residential treatment is to teach patients to tolerate distress. And often when we encourage them to use their coping skills, they'll say, I've tried them all and coping skills don't work for me. I tell patients that coping skills are like muscles. The more they use them, the stronger they become. So hopefully as the patient spends more time at higher level of care treatment, they will practice their coping skills and they'll start to become more effective and the patient will be less distressed. One size doesn't fit all. Some special considerations for higher level of care. There are some challenges in Obtaining residential treatment for people who live in larger bodies, unfortunately, sometimes it's difficult to get insurance to pay. You can usually get insurance coverage for somebody who has a significant amount of weight to gain, but for the person who doesn't need to gain weight, or for the person who is binging or purging, but they no longer have any electrolyte abnormalities, sometimes it's hard to get insurance to continue to pay. It's definitely not impossible, but it requires a lot of advocacy by the treatment team to get insurance to understand why remaining at higher level of care is just as important for the person who lives in a larger body as it is for the person who needs to restore weight. Also, I've had patients say that sometimes the group programming may feel like it's more geared toward anorexia or for people who need to gain weight. For some patients, residential treatment is too much. Some people deteriorate in the supportive 24/7 environment, and this is especially true for patients who have borderline personality features. These patients may struggle, they may actually become less stable, and often the natural impulse when that happens is to think, oh, this person needs a higher level of care. Maybe they need to go inpatient. But sometimes, if this patient's not suicidal, I actually like to hit the pause button and suggest to the patient, maybe you need a lower level of care. Maybe this is just too much for you being in this emotionally intense environment. That doesn't usually go over very well with patients, but sometimes it can be a little bit of a reset just to let them know that, look, if you're going to be here, we do expect you to use all your coping skills to stay grounded and glued together enough actually to participate. Patients who have autism can sometimes struggle at residential level of treatment because often there are a lot of people around. There may not be many opportunities for privacy. They may become overstimulated. Treatment dependence can also be an issue for some people. There's a therapist that I work with who often says the goal of treatment is not more treatment. But for some people, the goal of treatment is more treatment, and they become rather dependent on treatment. And so we have to kind of help those people start picturing life after treatment and get them moving toward that instead of having them just focus on staying in treatment forever. Let me talk a little bit about trauma. It may be very appealing to think that a patient who has an eating disorder and a trauma history will go to residential treatment and they can get their trauma addressed and their eating disorder addressed. And that might happen. It doesn't always happen though, because remember the balloon analogy that I talked about? We're going to clamp down on the eating disorder behavior while a person is here. Other impulses and emotions are going to be splooging out. That might not be the time when we can really start working on trauma. So the amount of trauma work that a patient will be able to do while they're in residential treatment depends on the skills of the therapists that work there, but it also depends a lot on the stability of the patient. And for some people, simply containment has to be the goal at residential treatment. And we remind that patient that ultimately the trauma work is something that will need to continue over the course of years as they move on to outpatient therapy. A quick note for patients who have comorbid substance use disorders and eating disorders, sometimes it can be a little tricky, sort of a chicken and the egg kind of thing. A person may need to go to detox before they can go to eating disorder treatment, and some detox programs, understandably, are hesitant about admitting patients who have significant eating disorders. So sometimes it requires a little bit of extra legwork to figure out the order of treatment that needs to occur for those folks. Residential treatment, does it work? I wish I could cite for you a long list of references indicating demonstrating the effectiveness of residential treatment. I've worked in residential treatment for 16 years. Obviously, I believe in it. I love the freedom that we have at residential treatment to do innovative things. I love working with patients in community, but the reality is we don't have the clinical evidence that I wish we had to support its effectiveness. And there are some reasons that we don't have that data. One of the main reasons is that most of the residential eating disorder treatment programs in the United States are for-profit. And so they are not being conducted at academic medical centers where high quality research often occurs. There may be a commercial or financial bias for residential treatment facilities to be able to demonstrate positive outcomes because they want to stay in business and get more patients. But because of that, it is difficult really to get very well done research looking at the effectiveness of residential treatment programs. I hope that's something that will change. But right now, that's just kind of what it is. So how do you help your patient access treatment? Unfortunately, the first thing you have to find out is what their financial means are. Most of the time, patients have to have private insurance in order to have residential treatment, plus minus on whether they have to for inpatient treatment. If people have Medicaid, they may have very limited options, if they have options at all, for residential treatment. Some people are able to pay out of pocket, but most of us don't have the resources to do that. If you're somewhere 24/7, the bill mounts quickly, and that's just not something that a lot of people can do. You need to know the age of your patient. There are programs that are specifically for adolescents, it's specifically for adults. It can be more challenging to find a treatment program for folks who are non-binary, or for males, or for patients with diabetes, or patients who are pregnant. Definitely not impossible, but just know that not every program will be able to take those patients. And so I encourage you to know what the eating disorder resources are in your state and your region and beyond. I think sometimes people who are entering the eating disorder treatment arena don't know that they may have to go out of state, or they may have to take an airplane ride to get to a treatment facility. And so you may play an important role to educate them that, yeah, I know it sounds like this is a really big deal and a big commitment. It is, but this is necessary so that you can get specialized treatment. What do you do when the patient says, I just want to do outpatient treatment? If the patient truly needs a higher level of care, I would discourage you from agreeing to take them at an outpatient level. The risk of refeeding syndrome is not something that I would want to manage as an outpatient clinician. There could be significant liability issues. And if the patient is going home, they may continue to do their potentially life-threatening behaviors, and there's not a way for the cycle to be interrupted. So you may need to remind the patient of all of those things and tell them that if they go to higher level of care, they'll be able to have medical monitoring to prevent refeeding syndrome. There will be a dietitian to help them with meal planning. They will have meal support, and they can use the higher level of care as a launch pad to step down to lower level of care. So what do you do when your patient returns to you after inpatient or residential treatment? I hope that you're more familiar now with the experience that they might have had, and I have a couple of tips for how to engage with patients right after they return from higher level of treatment. First, please do not tell the patient that they look healthy. Tell them they look great. They are very likely to be uncomfortable with changes in their body, and it won't be helpful for you to provide even a well-intentioned comment. And I have stepped on this landmine before, but please don't give editorial comments about a person's body. Their eating disorder voice is likely to distort even a well-intentioned comment into something that might be hurtful. So instead, I recommend that you just greet the patient and tell them the truth. It's nice to see them. And then take your cues from the patient and know that even though they're finished with higher level of care, they still may have mixed feelings about the entire recovery process. Please allow the patient returning from higher level of care not to be okay. Often patients fear that when they leave higher level of care, everybody in their life will expect them to be fixed. They'll think that the eating disorder is gone and the person is okay. And that puts an enormous amount of pressure on patients. It's scary to leave 24/7 treatment and go to only having contact with the outpatient team every few days or weeks. So patients are likely to need reassurance that it's okay still to have needs. Remind them that they're not alone. And even if they're doing better, you're going to be there to support them. Blind weights. If weighing patients is part of your practice, please, please, please do a blinded weight. So in other words, have the patients back to the scale and don't tell them what the number is. more than likely the patient has had blinded weights when they've been at higher level of care, and it can be extremely upsetting for them to come and go to a doctor's appointment or something and to be told their weight. Please make sure also that your staff don't tell the weight. And unfortunately, a lot of electronic medical records now automatically print the weight on the after visit summary that is given to the patient. So if you have a chance to intercept that piece of paper and mark out the weight or even tear off that little piece of paper, please do it. I cannot tell you how many patients I've had who were really devastated when they went to an outpatient appointment and found out their weight, especially if they get that piece of paper when they're walking out the door and then they don't have a chance to process their emotional reaction to the number that they see. Y'all do the heavy lifting. I've done inpatient residential work and outpatient work. I think outpatient work is much harder. So thank you very much for taking care of patients, for helping them get to higher level of care when it's needed, and for receiving them back after they finish that treatment. I am happy to answer questions.
Thank you so much, Dr. Foreman, for such a wonderful presentation. As a reminder, slides will be sent out after today's webinar has concluded, and any unanswered questions will be sent via email 1 week from today with responses from Dr. Foreman. Our training center will also house this presentation within the on-demand section 2 weeks from today's date. I'll now go into questions that we can answer during the time we have left. The first question reads, haven't there been some recent challenges to the reliability and validity of BMI?
Yes, for sure. Yes. You'll note I didn't even really talk about BMI as a criteria for a person being hospitalized. And I have worked really hard at the hospital where I work to dispel the myth that a person has to be below a certain BMI in order to need inpatient treatment. So absolutely, BMI appropriately is under a lot of criticism as not being racially inclusive, not taking age of people and body maturation processes into consideration. So yes, BMI is under a lot of scrutiny.
Thank you so much for that response, Dr. Foreman. The next question reads, as an outpatient therapist, I don't get to take measurements like heart rate, blood pressure, etc. How do I know when to suggest inpatient treatment?
I think you probably have to try to collaborate with the person's primary care clinician, and it's hard. The training in medical school regarding eating disorders is very, very limited, unfortunately. And eating disorders kind of live in the land between medical and psychiatric. And because of that, sometimes they sort of are a black hole, and neither the mental health providers get that much training and the medical clinicians may not get that much training. So I would say try to collaborate if the person has a dietitian, if they have a primary care clinician that you can express your concerns about. And then I've had many patients who said, the only reason I'm here is because my therapist said they're not going to continue to work with me if I don't get treatment. So the power of the relationship that you have as a therapist with your patient is very, very strong. Whenever I meet a new patient, I always ask them about, who are your sources of emotional supports? And it's surprising how many patients will identify their therapist as their primary source of emotional support. So, sometimes you have to leverage that relationship also. But you're right, in absence of the vital signs and everything, or even being able to weigh them, it's very hard. So I think you would probably need to collaborate with their other clinicians.
Thank you once again, Dr. Foreman. The next question reads, how do you prevent refeeding syndrome?
So the way that's a really good question. The way to prevent refeeding syndrome is to start with a fairly conservative meal plan. And we get daily labs just to make sure that the phosphorus and magnesium are not getting low. And then you can increase the amount of the meal plan every few days. There are sort of some protocols for doing that. There are a couple of different ways you can do it, but generally you start with a lower meal plan and then escalate it up, again with that target weight gain rate of 1 to 2 kilos per week.
Thank you once again, Dr. Foreman. The next question reads, blacking out the weight on the after visit summary makes a lot of sense. But what about the access patients have to their EMR and being able to see it there?
I don't have words. I don't have words for any of it. I think all of us know that something, that probably was well-intentioned to give people access to their information has many, many problems, not just in the eating disorder world. I have a friend receiving treatment for breast cancer right now, and she found her pathology report before her doctor called her, just absolutely devastating things. I don't know a way to keep that particular part out. At my hospital, we're able to withhold some of the mental health notes, but I don't even know if we can withhold the weight and the vital sign data from patients. So I'm sorry, I don't have a helpful answer.
Thank you. And I'll take one more question and then we'll send the remaining responses out within a week. The next question reads, I wish I could work independently as a peer support specialist on this matter. Any chance it could be governed under a life coach?
I don't know that I really understand the question. Could you read it again?
So it
Peer
says,
support.
I wish I could work independently as a peer support specialist on this matter. Any chance it could be governed under a life coach versus using a peer support specialist?
I'm not exactly sure what the question means. I think the use of the word governed is throwing me a little bit. And I know that life coaches can also get some certifications, but then I don't know where peer support fits in. So I'm really sorry. I'm not quite sure how to answer that.
No problem at all. I will send you this question again. And the person that wrote this question, Ms. Stallings, if you're able to resend this, that would be great. I see that someone wrote in the chat that peer support is billable to medical in California. So it may be that that is what this question is referring to.
Awesome.
Yes.
Cool.
So,
Okay.
mhm.
Yeah, no, that may be a regional thing that I'm not aware of. That's pretty cool, but unfortunately, that's not something I know anything about.
Okay. Thank you so much, Dr. Foreman. I want to thank you all for joining today's webinar. We truly appreciate your time. Dr. Foreman, do you have any last parting words or thoughts that you'd like to give the audience before we conclude?
Just to thank everybody again. This is really, really hard work. And sometimes I tell the trainees that I work with that I feel like I have to show up at work every day with a big invisible bag of hope and keep doling it out to the patients. But the work that we do really does matter. And we never know whether what we say during an encounter plants a seed that will bear fruit later that we may not get to see, but that does end up making a big difference for the patient. So thank you for what you do.
Thank you as well. And I just want to say that we will go ahead and conclude today's webinar and keep an eye out for the evaluation and the webinar slides at the end. Thank you once again, Dr. Foreman. Everyone have a great day.
Thank you. Bye.
Bye.